Welcome to the Deep Dive. Today, we are plunging into a topic that is as challenging as it is critically important, the incredibly complex world of burn injuries.
It's a field that truly tests the limits of medical knowledge and coordinated care. What might seem like a simple skin injury can hide layers of systemic damage and require incredibly specialized treatment.
Our guide for this deep dive, the source we're drawing from, is a detailed chapter from a highly respected surgical text, Bailey and Love's Short Practice of Surgery. It's packed with information.
Absolutely. And our mission today is to unpack that for you. We want to give you that shortcut to being truly well informed on this topic. We'll explore everything from, how often burns happen and what causes them,
Right.
to the intricate ways they affect the entire body, how experts assess the damage, the immediate care needed, and then the sophisticated treatment strategies, including surgery and long-term rehabilitation.
Think of this as getting the essential insights that the experts rely on, distilled and explained. Because, as the source makes clear, burn injuries are far more complex than just damaged skin. They are multi-system traumas demanding precision and, well, a deep understanding of the body's response.
So let's start with the big picture. How common are burns and where do they typically come from?
Well, the source highlights that the incidence of burn injury varies hugely around the world. It's influenced by everything from poverty levels to cultural practices, but it gives us some specific numbers for a developed nation like the UK, with a population of around 67 million.
And those numbers are quite revealing, aren't they? They show that roughly 175,000 people visit emergency departments in the UK every single year because of burns.
175,000, that's a lot.
It is. And out of those, about 13,000 are serious enough to require hospital admission. And then around 1,000 patients per year suffer severe burns needing critical care and, crucially, fluid resuscitation.
Wow, 175,000 visits. That's a significant public health burden right there, even before getting to the admitted cases. And the source points out something particularly striking about the most severe burns, right? The ones needing fluids.
It does. About half of those patients with severe burns requiring fluid resuscitation are under the age of 16.
Half. Under 16.
Yeah. This immediately tells you that children are incredibly vulnerable to these severe injuries.
That's a powerful statistic.
Yeah.
Does the way people get burned also differ depending on their age?
Absolutely. And this is a critical insight for understanding prevention and initial assessment. The source emphasizes that the extremes of age, the very young and the very old, are especially vulnerable.
Okay.
In children, the overwhelming majority of burns are scalds. So you think about accidents at home, pulling a kettle, knocking over a hot pan, hot drinks, or, getting into bath water that's too hot.
Everyday household risks become major dangers for little ones.
Precisely. For adolescents, burns are more commonly linked to risk-taking and experimentation, often involving things like matches and flammable liquids.
Oh, right.
As people move into adulthood, flame burns become more frequent. But scalds and contact burns, like maybe falling against a hot radiator or being unable to move away from a hot surface quickly, remain common, and that actually become more likely with increasing age.
So for older adults, the burn itself might signal another problem, like increasing frailty.
That's exactly right. The source points out that a burn injury in an elderly patient can often be the event that reveals increasing frailty or a reduced ability for self-care that maybe wasn't previously recognized. It can be a warning sign about their overall health status.
That's a really important clinical observation. What about other types of burns mentioned? Electrical, chemical?
Yeah, electrical and chemical injuries are seen predominantly in adults, and these are frequently associated with specific occupations. Rarer thermal injuries, like cold burns or radiation burns, are also mentioned, but they are less common overall.
And are there underlying conditions that are frequently associated with burn injuries in adults? The source mentioned something quite startling here.
This is a sobering point from the source, yes. In some populations, associated conditions like mental health issues, including things like attempted suicide or sole epilepsy or alcohol and drug abuse, can be underlying factors in as many as 80% of adults admitted with burns.
80%. So for a large majority of adult patients in some settings, the burn isn't just a random accident. It's connected to significant pre-existing health or social challenges.
Exactly. And this leads directly to another critical point highlighted, particularly in vulnerable groups like children and the elderly, the absolute necessity of screening for non-accidental burn injury, or NABI.
NABI. This is listed as a critical trigger for concern. What specific signs should raise suspicion?
The source lists several key indicators: a delay in seeking medical care or a perceived lack of concern from the caregiver. That's a major red flag. Inconsistency between the story given about how the burn happened and the actual pattern or depth of the injury is another crucial sign. Does the burn look like the explanation provided?
So if the physical evidence doesn't quite match the narrative.
Precisely. Finding other unexplained injuries, such as bruises or fractures, in addition to the burn, should also raise immediate suspicion. Frequent hospital attendances for various issues can be another pattern that warrants investigation.
Right.
The source really stresses that any of these findings must trigger concern, lead to further investigation, and crucially, require alerting senior staff immediately because safeguarding the patient is paramount.
That's a clear mandate for action. Given the frequency and severity of burns, prevention is obviously huge. Has it been effective?
It has, thankfully. The source highlights that prevention measures through legislation, public health promotion, and improvements in how products are designed have had a significant impact in reducing burn incidents.
Can you give us some concrete examples of effective prevention measures mentioned?
Certainly. Regulations mandating flame retardant materials in clothes and furniture have definitely helped. The widespread promotion and use of smoke alarms are obvious lifesavers.
Of course.
Improvements in the design of cookers and gas fires have reduced household accidents. And think about the almost universal shift to cordless kettles. That simple design change has prevented countless scalds in children just by eliminating those dangling cords they could pull.
Simple, but so effective.
Yes. Education is also key. Parents are educated, for instance, to set hot water thermostats to 60 degrees C maximum in their homes. That helps prevent severe scalds from bath water, which are particularly dangerous for young children with thin skin.
Makes sense.
Recent campaigns have highlighted the dangers of things like hot hair straighteners left within reach of children, and a powerful slogan often used for scald awareness is "Hot water burns like fire," really emphasizing how quickly hot liquids can cause deep damage.
That phrase certainly sticks with you. So in essence, prevention is about safety regulations, public education, and smart design. A combined approach.
Exactly. A multi-pronged approach addressing the environment, behaviors, and products.
Okay, let's move from how burns happen and how to prevent them to what actually happens to the body when it's burned. The source dives into the pathophysiology, starting with the skin.
Right. While a severe burn impacts multiple body systems, the skin is the initial and most common organ affected. And understanding the skin's normal structure and incredibly diverse functions is absolutely fundamental to grasping the consequences of burn injury and how it's treated.
What are the key functions of the skin that are immediately disrupted by a burn?
Well, the source lists several vital roles. It's our primary waterproof barrier and protects us from ultraviolet light. Losing this barrier means massive fluid loss. Water quite literally leaks out and increased vulnerability to sun damage. It's also a crucial part of our immune system, defending against infection.
And we know burn patients are highly susceptible to infection. That barrier loss is a key reason.
Precisely, in part because that barrier is gone and the whole immune system is kind of knocked off balance. The skin also regulates body temperature thermoregulation. Severe burns abolish this, making patients incredibly vulnerable to getting too cold or too hot.
Okay.
It's involved in vitamin D production, facilitates movement, provides sensation through nerve endings, and, of course, plays a huge role in our appearance and identity cosmesis. Losing these functions creates profound challenges for the burn patient, from fluid imbalance and temperature instability to infection risk, mobility issues, loss of feeling, and major psychological impact from altered appearance. It's devastating.
Beyond the skin itself, one of the most immediate and life-threatening concerns is injury to the airway and lungs, known as inhalation injury.
This is extremely serious and often complex. When someone is exposed to hot, smoky air in a fire, they can suffer inhalation injury. The source breaks this down into 3 components that can occur alone or together: injury to the upper airway, injury to the lower airway, often called true smoke inhalation, and metabolic poisoning from inhaled toxins.
How does the upper airway get injured? Is that just from the heat?
Mostly, yes. This typically happens with burns to the face and neck, especially when the person has been trapped in an enclosed space like a burning room or car. The hot gases directly damage the tissues in the pharynx and larynx. That history of being in an enclosed space is a major red flag here.
And what are the key warning signs that suggest someone might have sustained burns to their respiratory system? What should you look for?
The source provides a clear list that demands attention. Visible burns around the face and neck, blistering inside the mouth, that history of being trapped, any change or hoarseness in the patient's voice, and singeing of the facial and nasal hair. These signs should immediately trigger suspicion for inhalation injury.
The source also details the specific dangers of inhaling different things in a fire, hot gas, steam, smoke.
Yes, inhaling hot gases primarily causes burns to the supraglottic area, that's the structures above the voice box, leading to dangerous swelling, laryngeal edema, which can rapidly obstruct the airway.
And steam is worse.
Steam is particularly insidious, yes. Because it contains much more thermal energy, it can penetrate deeper into the airways, causing subglottic burns below the voice box and damaging the delicate lining of the respiratory tract, the epithelium. Smoke particles themselves can cause chemical pneumonitis, basically inflammation and damage deep in the lungs, leading to respiratory failure.
So it's a nasty mix of heat damage, chemical irritation, and physical particles lodging in the lungs.
Exactly. And then there's the third component, metabolic poisoning from inhaling toxic gases.
The source focuses on carbon monoxide and hydrogen cyanide here. CO is the big one.
Carbon monoxide, or CO, is cited as the most common immediate cause of death in fires. It's a silent killer, odorless, and colorless. Its danger lies in its fierce attraction to hemoglobin, the molecule in your blood that carries oxygen. CO binds to hemoglobin about 250 times more tightly than oxygen does.
Wow, 250 times.
Yeah. This creates carboxyhemoglobin, which simply can't carry oxygen, drastically reducing the amount of oxygen delivered to your tissues.
So even if you're breathing oxygen, it can't get picked up properly by the blood.
That's part of it. But it's even more sinister. CO also directly interferes with how your cells use oxygen. It competes with oxygen for binding to cytochrome oxidase, a crucial enzyme in the mitochondria, the powerhouses of your cells. This disrupts the electron transport chain, effectively crippling aerobic metabolism and the cell's ability to produce energy.
So it affects oxygen transport and oxygen utilization at the cellular level, a double whammy. How is CO poisoning treated?
Early recognition is absolutely key, followed by administering high-flow, high-concentration oxygen. The goal is basically to overwhelm the CO with oxygen, helping to displace it from hemoglobin and get it out of the system.
And hydrogen cyanide, where does that come from?
Cyanide is produced by the burning of certain nitrogen-containing polymers, like plastics and synthetic fabrics often found in modern buildings and furnishings. Hydrogen cyanide works differently from CO, but has a similar devastating effect on cellular energy production. It binds to the trivalent iron in mitochondrial cytochrome A3 complex, another key enzyme in the electron transport chain. This just stops cellular respiration cold.
So both CO and cyanide are fundamentally attacking the body's ability to create energy at the cellular level, just through slightly different biochemical steps, causing a kind of cellular suffocation.
That's the core insight. They both cause a form of cellular suffocation. And finally, related to breathing, the source mentions a mechanical issue, a mechanical block on rib movement.
From full-thickness chest burns, right? The skin gets too tight.
Right. Full-thickness burned skin loses its normal elasticity. It becomes stiff and leathery, like a rigid shell. If this deep burn wraps around the chest, this inelastic eshur, that's the term for the burned skin layer, combined with the inevitable swelling, the edema beneath it can act like a vice. It physically prevents the ribs from expanding when you try to breathe.
Oof.
This significantly compromises respiratory function, even if the lungs themselves are spared.
It's like trying to breathe while wearing a concrete vest.
A very painful, very rigid concrete vest. It's another reason why deep chest burns are so dangerous.
Okay, beyond the initial injury to skin and airway, the source talks about the widespread inflammation and circulatory changes that happen throughout the body after a significant burn. This isn't just local redness around the burn, is it?
Oh, far from it. It's a complex whole-body response. The injured skin and the presence of the burn eshur trigger a massive inflammatory cascade that affects multiple systems.
The source gets into some detailed biochemical pathways. Lots of factors activating. What's the simplest way to understand this complex process for us?
Think of it like this. The heat and tissue damage trigger sensory nerve fibers and alter proteins. This sets off a chain reaction, releasing chemical messengers, activating immune system components like complement, and kicking off complex pathways involving substances like Hagman factor, which in turn affects clotting and inflammation cascades.
Okay, so a big chain reaction.
Right. Without getting lost in all the technical names, the key outcome of this massive inflammatory response is vastly increased vascular permeability.
Vascular permeability. meaning the blood vessels get leaky.
Exactly. It means the walls of your tiny blood vessels, the capillaries, become incredibly leaky. Water, salts, and even large proteins that should normally stay inside the blood vessels leak out into the surrounding tissues. This leads to massive edema formation, widespread swelling, not just at the burn site, but potentially throughout the body.
Like the body is leaking from the inside out. That sounds dramatic.
In a way, yes. The volume of fluid lost this way is directly proportional to the area of the burn. The source describes this fluid loss as leading to the shock reaction after burns. Above a certain threshold for adults, burns covering more than 15% of their total body surface area, or TBSA, this fluid loss is so profound that it causes hypovolemic shock.
Meaning low blood volume shock.
Yeah.
Because all the fluid is leaked out.
Exactly. Not enough fluid volume circulating effectively within the blood vessels. And that absolutely requires aggressive fluid resuscitation to prevent organ damage and death.
That explains why calculating burn size, which we'll cover later, is so foundational to treatment. What other life-threatening complications can arise from these complex changes in major burns?
Well, major burns significantly impact several other vital systems. The immune system is severely affected. The systemic inflammatory changes lead to significant suppression of cell-mediated immunity, especially in large burns.
Making patients very vulnerable to infection.
Highly vulnerable. They become much more susceptible to bacterial and fungal infections. These infections can originate from the burn wound itself, which is a large open area, obviously,
Right.
but also from the lungs if there's inhalation injury, and from necessary medical equipment like central venous lines, tracheostomies, or urinary catheters. Lots of potential entry points.
So a compromised immune system and multiple entry points for bugs. A dangerous combination.
A very dangerous combination. Another critical area impacted is the intestine. The inflammatory stimulus and the shock reaction cause damage and reduced blood flow, ischemia, to the gut lining, the mucosa. This slows down gut movement, making it hard or impossible to absorb food.
So nutrition becomes a major challenge straight away.
Absolutely. The inability to feed a patient enterally, that is, through their gut in large burns, is a life-threatening complication in itself. This gut damage also increases something called translocation of gut bacteria.
That's it.
It means bacteria that normally live harmlessly in the gut can cross the weakened mucosal barrier and get into the bloodstream, becoming a significant source of systemic infection in large burns.
Bacteria leaking from the gut. That sounds really bad.
It can be. Furthermore, the swelling in the gut lining, coupled with fluid buildup in the abdomen, can lead to something called abdominal compartment syndrome. This is where pressure builds up inside the abdominal cavity.
And that pressure can affect other organs, like breathing.
Yes. It physically pushes up on the diaphragm, making it harder to breathe, and increasing the airway pressures needed for ventilation if the patient is on a machine, adding to the respiratory challenges we discussed earlier.
It's like a domino effect of complications spreading through the body.
It really is. And finally, there's the danger to peripheral circulation, especially in the limbs. With full thickness burns, the tough collagen fibers in the skin are damaged and contract, making the skin stiff and inelastic. If this deep burn wraps all the way around a limb, a circumferential burn, as the limb swells with edema, that fluid leak we talked about, the inelastic burn Escher acts like a tight band, a tourniquet.
Constricting blood flow to the hand or foot.
Exactly. If this isn't quickly released, the pressure builds, blood flow is compromised, and the limb tissue can suffer ischemia, lack of oxygen, potentially leading to tissue death and needing amputation.
So to recap the major life-threatening complications beyond the initial burn and airway injury. Widespread infection risk due to immune suppression and open wounds, problems with gut function and potential for infection from gut bacteria, abdominal compartment syndrome affecting breathing, and circumferential burns cutting off circulation to limbs. It's a cascade.
It really paints a picture of why major burns are such complex, multi-system traumas requiring specialist care.
Right, so we understand the dangers. Now, let's talk about the immediate response. The source starts with pre-hospital care. How vital are those first few minutes and hours?
Good pre-hospital care is absolutely foundational. It can significantly influence the patient's outcome by ensuring rapid assessment, appropriate initial treatment, and timely transfer to specialist care if needed.
What are the absolute key principles for someone giving first aid, whether they're a first responder or just a person on the scene?
First, and paramount, is rescuer safety. Especially in electrical or chemical incidents or building fires, you cannot help if you become a casualty yourself. Assess the scene for dangers before approaching.
Safety first, always. What's next?
Stop the burning process. If clothing is on fire, the simple stop, drop, and roll technique is effective. For chemical burns, this means quickly removing any contaminated clothing while protecting yourself.
And assess the patient beyond the burn. Don't get tunnel vision.
Exactly. You need to check for other injuries. Apply standard trauma principles, check ABC, airway, breathing, circulation, and do a rapid survey for things like fractures or other injuries that might have occurred during the incident, especially from explosions or falls while escaping.
That makes sense. And then, famously, cool the burn. How important is cooling and how should it be done?
Cooling the burn wound is incredibly important first aid. It provides significant pain relief. Crucially, it helps to slow down the ongoing damage within the tissue that delayed microvascular damage that can make a burn worse over time.
Okay.
Cooling is most effective if started within about an hour of the injury and should be continued for a minimum of 20 minutes. It's particularly beneficial for partial thickness burns, especially scalds.
What temperature of water? Should you use ice?
No, definitely not ice. The source recommends using tepid water around 15 degrees C, particularly in temperate climates. It is absolutely vital to avoid hypothermia, getting the patient too cold, especially in vulnerable groups like very young children and the elderly. Using ice or prolonged cooling with very cold water can actually be harmful. So, tepid water, minimum 20 minutes, avoid making them shiver.
Got it. Tepid water, 20 minutes, keep them warm overall. What else in terms of first aid?
Give oxygen if possible. Anyone involved in a fire in an enclosed space, particularly if they have any altered consciousness, should receive high flow oxygen because of the risk of carbon monoxide poisoning we talked about.
And elevate.
Elevate burned areas where possible. Simply sitting a patient up who might have a burned airway can be life-saving if transfer is delayed, helping to keep the airway open by reducing swelling. Elevating burned limbs helps reduce swelling and makes the patient more comfortable.
And manage pain.
Yes, administering appropriate analgesia before or during transfer is vital for patient comfort and helps with subsequent assessment and treatment back at the hospital.
So that's the critical first aid and transfer. What happens when the patient arrives at the hospital? Does the approach change?
In the hospital, the immediate care of a burn patient follows the standard principles of advanced trauma life support, or ATLS, just like any other major trauma. This systematic approach ensures all potential life threats are addressed in order, going through the AF assessment. Airway control, breathing and ventilation, circulation, which is where fluid resuscitation really ramps up, disability, checking neurological status, exposure with environmental control, preventing heat loss, and fluid resuscitation again as a key intervention.
It's a standard roadmap for critically ill patients, isn't it?
Exactly. As part of this, healthcare teams must actively look for and treat any additional injuries that might not have been immediately obvious based on the patient's history and a thorough examination. The source reinforces that the major factors determining how severe a burn is and guiding treatment are the percentage of total body surface area, TBSA, burned, whether there's inhalation injury, the depth of the burn, and the patient's age, and any pre-existing health conditions or comorbidities.
Those factors really dictate the complexity of care needed. And not every burn patient needs to go to a specialized burns unit, right? There must be criteria.
Correct. The source provides clear criteria for when a patient must be acutely admitted to a specialist burns unit. These include any suspected airway or inhalational injury, any burn large enough that it's likely to require fluid resuscitation, or any burn deep enough that it's likely to require surgery.
So size, depth, and airway involvement are definite triggers for specialist care.
Yes. Also, burns of any significant depth or size to particularly critical areas like the hands, face, feet, or perineum warrant specialist care. This is because of the high functional and cosmetic importance of these areas.
Makes sense.
Patients whose social situation or psychiatric background makes safe care at home difficult should also be admitted to a specialist unit. Any suspicion of non-accidental injury is a mandatory criterion for specialist care and investigation. And any burn in a patient at the extremes of age, the very young or the very old, should be managed by a specialist unit.
What else triggers a transfer?
Finally, burns from high-tension electricity or concentrated hydrofluoric acid, which have specific complex complications that we'll discuss later, also require specialist admission.
That's a comprehensive list, ensuring the right patients get to the right place quickly. Let's return to that ATLS sequence in the hospital, starting with airway management. Recognizing a potentially burned airway is crucial.
It's paramount. The same warning signs we discussed for pre-hospital care or what clinicians look for. A history of being trapped in a smoky or hot enclosed space, burns on the palate or inside the nose, absence of nasal hairs, deep burns around the mouth and neck, or any change or hoarseness in the voice.
And the main problem with a burned airway is swelling, right? It can close off.
Exactly. The tissues become inflamed and swell, and if this isn't anticipated and managed proactively, that swelling can completely block the upper airway. The source emphasizes that securing the airway with an endotracheal tube, putting a breathing tube down the windpipe, is the treatment of choice when a burned airway is suspected. This tube stays in place until the swelling resolves, typically around 48 hours.
Why is intubation stressed as needing to happen early, even if the patient seems okay initially?
Because of the signs that the airway is swelling to a dangerous level, like voice change, stridor, that harsh vibrating sound when breathing, anxiety, or obvious respiratory difficulty are very late indicators. By the time those symptoms appear, the swelling is often so severe that attempting to insert a breathing tube becomes incredibly difficult, sometimes impossible.
A dangerous situation.
Very. The source warns that if intubation is attempted in a delayed situation, equipment for an emergency cricothyroidotomy, creating an airway surgically in the neck, must be immediately available. It's a last resort.
That highlights how quickly things can deteriorate. Is there a typical time window for this swelling to become critical?
Yes, airway occlusion usually happens between 4 and 24 hours after the burn. This provides a window of opportunity for senior staff and an experienced anesthetist to make a reasoned decision and perform the intubation electively if suspected, rather than waiting for an emergency. The source also notes that treating smoke inhalation often requires not just the tube, but mechanical ventilatory support, sometimes for several weeks depending on the lung injury.
Moving on to breathing management, specifically for inhalational injury, where the lungs are affected by smoke. How do you manage that once the patient is in the hospital?
As we mentioned, anyone trapped in a fire for more than a couple of minutes should be observed closely, as symptoms can be delayed. Other clues in the hospital include visible soot in the nose or mouth and patchy areas of consolidation on a chest x-ray.
And the clinical signs might not show up right away. They can be delayed.
That's a key point. They can be delayed anywhere from 24 hours up to 5 days. These signs include a progressive increase in how hard and how fast the patient is breathing, their work of breathing and respiratory rate, a rising heart rate, anxiety, confusion, and a drop in their oxygen saturation levels.
How is inhalational injury treated once suspected? Is it just oxygen?
Treatment starts as soon as suspicion is high and the airway is secured if needed. It involves supportive measures like physiotherapy to help clear secretions from the airways, nebulizers to deliver medications as a mist directly into the lungs, and giving warm, humidified oxygen. The patient's progress is monitored closely by checking their breathing rate and measuring blood gas levels regularly.
What if they get worse despite that?
If their breathing deteriorates, they may need support like continuous or intermittent positive pressure ventilation delivered via a mask or a T-piece connected to the breathing tube. In the most severe cases, they will require full mechanical ventilation in the intensive care unit.
The source also mentions some specific therapies for the lungs damaged by smoke.
Yes. Nebulized heparin is sometimes used to help prevent the formation of fibrin-cast thick plugs in the airways, although its effectiveness may depend on the availability of a protein called antithrombin, which can be low after burns. Nebulized N-acetylcysteine, a mucolytic that helps break down mucus, may also be used and can potentially enhance the effects of heparin. Bronchodilators like albuterol are also valuable. They open the airways and may also help the damaged airway lining to repair and reduce inflammation.
So managing inhalational injury is about anticipating it from the history, supporting the patient's breathing, and using targeted therapies as needed while watching very carefully.
Exactly. Suspect it based on history. Start supportive care early, and watch very carefully for subtle signs of deterioration.
Are there other breathing issues from burns besides smoke inhalation and that tight chest pressure?
Thermal burn injury to the lower airway is less common and usually happens with steam inhalation, which carries more heat deeper. Management is similar to other inhalational injuries, primarily supportive care. The mechanical block to breathing from a full-thickness chest burn Escher, which we discussed, is usually obvious on examination. Signs include the patient visibly struggling to expand their chest, signs of carbon dioxide buildup in their blood, hypercapnia, and if they're on a ventilator, needing very high pressures to get air in.
And the treatment for that mechanical block is escharotomy, cutting the tight skin.
Precisely. Emergency escharotomy involves surgically cutting through the stiff burned skin of the chest to allow it to expand and relieve the constriction, letting the chest wall move properly with breathing.
Let's cover managing metabolic poisoning in the hospital, CO and cyanide. How is that approached?
Key clues, again, are the history of being in a fire in an enclosed space and any alteration in the patient's level of consciousness. If poisoning is even a possibility, blood gases must be measured immediately to check for levels of things like carboxyhemoglobin, for CO, and to assess for metabolic acidosis, which can be a sign of either or other poisons.
What are the target levels for CO poisoning treatment?
If carboxyhemoglobin levels are greater than 10%, the source says the patient should be treated with high-inspired oxygen for a full 24 hours to help displace the carbon monoxide from the hemoglobin more rapidly. Metabolic acidosis is also a common feature that needs monitoring and sometimes treatment.
And for cyanide poisoning, you mentioned a specific antidote earlier.
Yes, the modern treatment highlighted is the intravenous administration of hydroxycobalamin, which is a form of vitamin B12. This substance directly reacts with cyanide to form cyanocobalamin, a compound that is water-soluble and can then be safely excreted by the kidneys in the urine. Again, a strong suspicion from the history is key, and blood gas measurements help confirm the diagnosis and guide treatment for both CO and cyanide.
So, suspecting these poisonings based on the scenario and quickly doing blood tests are critical first steps. Now let's move to circulation and fluid resuscitation. You mentioned earlier that major burns cause massive fluid leaks. This seems central to burn care.
It absolutely is. This understanding, which developed particularly over the 20th century, dramatically improves survival rates for patients with large burns. Replacing that lost fluid is absolutely critical to prevent organ failure from shock. Standard guidelines and formulas are now widely taught and used by emergency staff to estimate how much fluid is needed.
And fluid resuscitation needs to start quickly, right? Counting from the time of the burn?
Yes, fluid resuscitation begins counting from the moment of the burn injury. If there's any delay in starting AV fluids, that missed time needs to be caught up as soon as possible once access is gained.
Who needs FOV fluids? What's the threshold?
Intravenous resuscitation is typically required for adults with burns covering more than 15% TBSA and children with burns covering more than 10% TBSA.
And children and the elderly need special consideration here too.
They absolutely do. Children require additional maintenance fluid, that's their normal daily fluid needs, separate from the burn resuscitation fluid because their metabolism and fluid balance are different from adults. Elderly patients need very careful monitoring during resuscitation due to their often pre-existing health conditions and how their aging bodies handle large fluid volumes.
Is oral resuscitation ever an option? Can people just drink lots of water?
If needed, for less severe burns or in situations where AV access is delayed, oral fluids can be used, but, and this is crucial, they must contain additional salt. Using pure water without added salt can dangerously dilute the body's sodium levels, leading to hyponatremia and potentially fatal water intoxication. Salted solutions, like those used for rehydration and diarrhea, for instance diarrhea in the UK, are necessary if oral resuscitation is used.
How do you calculate the initial IV fluid volume needed? What are the key factors?
The calculation is based on 3 key variables: the percentage of TBSA burned, the patient's weight in kilograms, and the rate and type of fluid being used. The source reminds us that the peak rate of fluid loss is in the first 8 hours after the burn. It slows down significantly by 24-36 hours, after which normal daily fluid replacement rates are usually sufficient.
And the source discusses 3 main types of fluids used for resuscitation: crystalloid, colloid, and hypertonic saline.
Yes. Crystalloid, which is the most common worldwide, colloid, and in some centers, hypertonic saline. Each has different properties, advantages, and disadvantages, and is used with specific approaches or formulas.
Let's start with crystalloids. The most common, what are they?
The most common crystalloids used are Hartmann solution or Ringer's lactate. These are preferred because their chemical composition and osmolality, how concentrated they are with salts and other solids, are closest to that of blood plasma. They're balanced salt solutions.
And how is the volume calculated and given? You mentioned the Parkland formula.
Yes. The most widely taught formula is the modified Parkland formula. It estimates the total fluid needed over the first 24 hours by multiplying the percentage TBSA burned by the patient's weight in kilograms by 4. That gives you a volume in milliliters.
Okay, TBSA percent times weight times 4.
Right. And the key administration schedule is to give the first half of that calculated 24-hour volume over the first 8 hours from the time of the burn, and the remaining second half over the subsequent 16 hours.
And for children, you need to add their maintenance fluids on top of that.
Exactly. For children, remember, you also have to give their normal daily maintenance fluid in addition to the burn resuscitation fluid calculated by Parkland. This is typically a dextrose saline solution calculated based on weight. 100 milliliters per kilograms for the first 10 kilograms of weight, 50 milliliters per kilogram for the next 10 kilograms, and 20 milliliters per kilogram for every kilogram over 20 kilograms, all administered over a 24-hour period.
So children get their burn fluid plus their normal daily fluid needs. What's the main downside of using crystalloids like Hartmann's?
Because the fluid leaks out of the capillaries so readily in burn shock, you need to give very large volumes of crystalloid. The source suggests about 8 times more than you would need if using colloid to maintain adequate blood volume. This high volume can lead to significant tissue edema or swelling throughout the body, which can cause its own problems.
What about hypertonic saline? That sounds like very salty water.
It is. Hypertonic saline is used in some centers. The idea here is to create a higher salt concentration in the blood, which helps pull fluid out of the body's cells and into the blood vessels, theoretically maintaining blood volume with less overall fluid given. Proponents suggest this can lead to less tissue edema and potentially reduce the need for procedures like escherotomies and intubations.
But there are drawbacks.
Yes, a significant drawback is that managing the resulting high sodium levels, hypernatremia, can be tricky and requires very careful monitoring. Prolonged high sodium can be problematic and potentially lead to kidney dysfunction.
And the third type, colloids. What are they?
The most common colloid used is human albumin solution, which is derived from donated blood plasma. Colloids contain larger molecules, like the albumin protein, that exert oncotic pressure, it's essentially a pulling pressure, that helps keep fluid within the blood vessels and counteracts the hydrostatic pressure pushing fluid out.
When are colloids typically given in burn resuscitation?
The source suggests they are preferably given after the first 12 hours post-burn. The rationale is that in the very early phase, the capillaries are so leaky that even the large protein molecules in colloid just leak out into the tissues, making it less effective and potentially contributing to tissue swelling. After that initial peak leakiness subsides a bit, colloids can be more useful for holding fluid within the circulation.
Is there a specific formula for colloids mentioned?
Yes, the Mir-Barkley formula is mentioned, which estimates fluid needs over the first 36 hours. A simplified version calculates one portion of fluid by multiplying the percentage TBSA by weight, kg by 0.5. 6 such portions are given over 36 hours on a specific schedule. One infusion every 4 hours for the first 12 hours, that's 3 portions. Then one infusion every 6 hours for the next 12 hours, 2 portions. And the final portion infused over the last 12 hours. The original formula actually used fresh frozen plasma, FFP, as the colloid.
And the drawbacks of using albumin or FFP?
Well, they're considerably more expensive than crystalloids, require specific storage in a blood bank, and giving excessive amounts can potentially put a strain on the kidneys.
So different fluid types, different formulas.
Yeah.
But how do you actually know if you're getting it right for the individual patient? How is fluid resuscitation monitored? It sounds like just following a formula isn't enough.
It absolutely isn't. Monitoring is critical because fluid resuscitation for severe burns is a dynamic process. The source explicitly warns against rigid adherence to any formula. The patient's response is what matters most.
What's the most important indicator you're watching?
The key monitor, the one everyone uses, is urine output. The target is generally between 0.5 and 1.0 milliliter per kilogram of body weight per hour for adults. It's a good reflection of how well the kidneys, and therefore other vital organs, are being perfused with blood.
But what if the patient isn't producing enough urine? What do you do?
If the urine output drops below the target, and the patient shows other signs of not getting enough blood flow to their tissues, things like a fast heart rate, cold arms and legs, cool peripheries, or signs of metabolic acidosis on blood tests like high lactate levels, then a fluid bolus is indicated. The source suggests a bolus of 10 milliliters per kilogram of body weight. You give extra fluid quickly and see if the urine output picks up.
And if they're making too much urine, can you give too much fluid?
Definitely. Over-resuscitation is also dangerous and can worsen edema, including in the lungs. If the urine output is consistently high, exceeding 2 ml per kilogram per hour, it suggests you're giving too much fluid, and the infusion rate should be decreased.
Are there other monitoring tools besides urine output?
Lactate levels in the blood are useful, especially in larger burns, as they indicate if tissues are getting enough oxygen for aerobic metabolism. Persistently high lactate or metabolic acidosis, despite seemingly adequate fluid resuscitation, can be a red flag that something else is going on, like mist carbon monoxide or cyanide poisoning impairing oxygen use.
Okay.
For patients with underlying heart or kidney problems, more invasive monitoring like central venous pressure measurement in an ICU setting might be necessary to guide fluid therapy more precisely.
So it's a careful balancing act, guided primarily by urine output and other signs of how the body is responding, rather than just sticking blindly to a formula calculated at the beginning.
Exactly. It's a continuous assessment and adjustment process, hour by hour in the early stages.
Moving on, temperature management is also highlighted as crucial immediate care. You mentioned earlier that burned skin loses its ability to regulate temperature. This must be a big issue.
It's a huge issue. Maintaining an adequate core body temperature is vital during the initial assessment and resuscitation. Losing large areas of skin makes patients highly susceptible to getting cold, even in a normal room temperature environment. Hypothermia, low body temperature, is incredibly dangerous in trauma patients.
It's part of that lethal triad.
Yes, it's part of what's sometimes called the lethal triad of trauma, along with acidosis, acid buildup in the blood, and coagulopathy, clotting problems. Being cold significantly worsens clotting issues and increases the risk of death.
So preventing hypothermia is a major priority right from the start.
Absolutely. Simple measures are crucial. Infusing intravenous fluids that have been warmed using external warming devices like forced air warming blankets, often called bear huggers, and simply increasing the ambient room temperature in the emergency department or assessment area can make a big difference. Keep the patient covered and warm.
So we've covered the systemic life support airway, breathing, circulation, temperature. Now let's focus back on the burn wound itself and how it's assessed. The first thing is always the size, right? The TBSA.
Yes, assessing the burn size, usually expressed as a percentage of the total body surface area, TBSA, is typically the first question asked and is fundamental to everything that follows. It dictates things like whether the patient needs fluid resuscitation, the method of transfer, and the resources required for their care.
How is TBSA estimated? The source mentions a few methods. The hand method.
Right. For small burns, say up to 10% TBSA, a useful quick estimate is using the patient's own hand, measured from the distal wrist crease to the fingertips. This area is roughly 1% of their TBSA. The source is a bit more precise at 1.25%, but acknowledges the inherent error and says 1% is a useful rule of thumb. It's a handy tool for quickly assessing small, patchy burns. Estimation above 15% in adults or 10% in children triggers the need for fluid resuscitation.
And for larger burns, the rule of nines. Is that still used?
The rule of nines is a widely used aid memoir, particularly helpful for quick estimation in the pre-hospital or emergency setting. It divides the adult body into areas that are roughly multiples of 9%. Each arm is 9%, the head is 9%, each leg is 18%, the front of the torso is 18%, split into chest 9% and abdomen 9%, the back of the torso and buttocks are 18%, and the genitalia are 1%.
That adds up nicely to 100%. It's been around for a long time, developed by Wallace, wasn't it?
It has, for about 70 years, but it has significant limitations that you need to be aware of. It tends to overestimate burn size, and it's quite inaccurate for obese patients where the body proportions change significantly. The arms and head become proportionally smaller, while the torso and legs become larger.
So it's a good rough guide for adults in an emergency, but you need to be aware of its flaws.
Exactly. And crucially, the rule of nines is not suitable for children under about 10 years old because their body proportions are very different from adults, particularly the relatively larger head size.
Which brings us to the London-Browder chart.
Yeah.
That sounds like the gold standard.
This is the standard chart used in burns units for accurate assessment and detailed documentation once the patient arrives. It was developed by, yes, Lund and Browder after treating victims of a major nightclub fire back in 1942. It's a detailed diagram of the front and back of the body divided into much smaller, specific anatomical areas.
And it accounts for age.
Critically, yes. It accounts for the changing proportions of the body with age, particularly in children. It also allows clinicians to shade in areas based on the assessed depth of the burn, not just the area.
So it's more precise and tracks changes over time.
Yes, it can be completed multiple times to document how the burn area or depth changes over time as the wound evolves or after surgery. It's also used in surgical notes to mark areas where skin grafts were taken from donor sites and where they were placed, grafted sites. The source notes that digital tools and apps are now available that allow you to shade a pictorial representation of the burn, and the app calculates the size and can even help estimate fluid requirements based on age and weight inputted.
Very useful. And how are burn size calculations adjusted specifically for children using charts like Lund and Browder? You mentioned the head size difference.
Because infants and young children have proportionally larger heads and smaller legs than adults, these dedicated charts are essential. At birth, a baby's head is about 18% TBSA, while each lower limb is only about 13.5%. The chart adjusts these percentages year by year, effectively subtracting 1% from the head's contribution and adding 0.5% to each leg's contribution annually until around age 10, when the body proportions become more adult-like.
So, summary of area assessment. Use the patient's hand for a quick estimate of small burns, around 1%, the rule of nines for a rapid adult approximation in emergencies, knowing its limitations, and the London Browder chart for detailed, accurate assessment and documentation, especially crucial for children due to their changing body shape.
That's the key takeaway for size assessment. Now let's talk about assessing the depth of the burn, which is arguably even more critical for determining treatment and predicting the outcome.
The first clue often comes from the history, right? How it happened.
Yes, how hot the burning agent was and, crucially, how long the skin was exposed to it. Burning of human skin is a function of both temperature and time. The source gives striking examples. It takes 6 hours for skin to be irreversibly damaged at 44 degrees C, but only 1 second at 70 degrees C to destroy the epidermis, the top layer.
1 second at 70 degrees. That's incredibly fast, like touching a hot stove element.
It highlights how quickly high temperatures cause deep damage. Another example given. 65 degrees C water, if contact lasts 45 seconds, it causes a full thickness burn. 15 seconds causes a deep partial thickness burn, and just 7 seconds causes a superficial partial thickness burn. This is why scalds, even from moderately hot liquids like tea or coffee, are so dangerous, especially for vulnerable thin skin in children or the elderly.
That really makes you think about how fast an accident with hot water can become serious. The source also lists typical causes and their likely depths in a table.
Yes, it's a useful guide. Scalds tend to cause superficial burns, but can have patches of deep dermal damage if cooling isn't immediate or the contact is prolonged. They are typically deeper in very young infants or the elderly due to thinner skin. Fat burns from cooking are often deep dermal or full thickness. Flame burns are usually a mix of deep dermal and full thickness. Chemical burns from alkalis, like cement, are often deeper than acids. Electrical contact burns are typically full thickness at the points where the electricity enters and leaves the body.
So history gives you a starting point for likely depth. How do you assess depth clinically just by looking at and examining the wound?
You look at the appearance and you test the sensation. A superficial partial thickness burn typically looks pink and moist, and when you press it gently, the color disappears, then quickly returns. That's capillary filling or blanching. Sensation to pinprick is normal. A deep partial thickness burn is often less moist, may look mottled red or white. And crucially, when you press it, the color doesn't blanch or return quickly because the capillaries and the deeper dermis are damaged. Sensation is reduced. The patient might feel pressure, but often cannot distinguish sharp from blunt touch.
And full thickness.
A full thickness burn looks hard and leathery, and the appearance can vary from looking almost like normal skin to being white, brown, or charred black, depending on the heat intensity. There is absolutely no capillary return or blanching. Because the nerve endings and the full thickness of the skin are destroyed, it is completely anesthetic. You could stick a needle deep into the burn area without the patient feeling pain, and it often won't bleed.
That difference in blanching and sensation seems like a key clinical differentiator. Let's break down the appearance and healing potential of those partial thickness burns a bit more. Superficial first.
Superficial partial thickness burns damage no deeper than the very top layer of the dermis, the papillary dermis. They usually have blistering, or the epidermis, the very top layer, is lost. The underlying layer, the dermis, is pink and moist and may ooze fluid for up to 36 hours. As we said, capillary return is brisk when you press it, and sensation is normal. The key thing is these generally heal well on their own without residual scarring, usually within 2 weeks, with just supportive treatment like appropriate dressings.
And deep partial thickness burns. What's happening there?
These go deeper, into the reticular dermis. The epidermis is typically lost, and the exposed dermis is often not as moist as superficial burns. There's often prominent fixed capillaries staining those small red or dark spots from damaged blood vessels that don't blanch with pressure, especially after 48 hours. Sensation is reduced. The patient can't reliably distinguish sharp from blunt with a needle.
And the healing is different.
Critically different. Without surgery, these deeper partial thickness burns take 3 weeks or longer to heal, and they almost invariably result in hypertrophic scarring that's thick, raised, often itchy, and contract. Problematic scarring.
So clinically distinguishing between superficial and deep partial is vital because one heals well on its own, potentially without a scar, and the other likely won't heal well without intervention and will leave a significant scar.
Exactly, and this brings us to the concept of two burn depths in terms of treatment strategy, which is really central to modern burn management. The source groups burns into two main categories based on their likely healing path and what treatment they need.
Group A and Group B.
Yes. Group A burns are those superficial enough to heal spontaneously and relatively quickly, typically within about 14 days, with an excellent functional and cosmetic outcome, provided they get optimal support and wound management. These are the superficial partial thickness burns.
And Group B, these are the deeper ones.
Group B burns are the deep, partial thickness, and full thickness burns. These are sufficiently reduced that if left to heal on their own by secondary intention, they would take a very long time, weeks or even months. This natural healing process involves the dead tissue, eschar, degrading and separating, the wound filling in with granulation tissue, and then the wound contracting significantly. This prolonged process usually results in poor function and severe scarring.
So what's a key principle for Group B?
The absolute key insight here is that the course of healing by secondary intention for these deeper Group B burns must be aborted and replaced with healing by primary intention. This means surgically removing the dead tissue and covering the wound directly with something, like a skin graft or a skin substitute, to achieve closure much faster and with a better functional and cosmetic result.
So the clinical assessment, looking at color, blanching, sensation, moistness, appearance, is really about putting the burn into Group A or Group B, because that decision dictates the fundamental treatment strategy, conservative versus surgical. The source has that helpful pictorial protocol linking the signs to the groups, doesn't it?
It does. Figure 46.5 visually links specific clinical signs, like whether the epidermis is intact, the type of blistering. Thin-walled suggests superficial, thick-walled deeper, how slippery the surface is, the color, pink versus mottled versus white-black, whether it blanches, how much sensation is left, the degree of oozing, any waxy appearance, and if hairs pull out easily, indicating damage to the follicle deep in the dermis, to the likely depth, from epidermal all the way to full thickness.
And it draws a clear line.
Yes, it visually draws a dividing line between burns likely to heal well on their own, Group A, shaded pink on the left of the diagram, and those that won't and will likely need surgery, Group B, shaded blue on the right. It also mentions the Nikolsky sign, where the epidermis easily peels away from the dermis with gentle sideways pressure. This usually indicates a more superficial injury within the epidermis or at the epidermal-dermal junction.
That visual guide makes the assessment process much clearer. So once you've assessed the depth and decided if it's Group A or Group B, how do you treat them differently? Let's start with Group A burns, the ones expected to heal well.
Okay, for Group A, the superficial partial thickness burns expected to heal well, there are two main goals of management. First, prevent anything that could make the burn deeper, essentially causing it to change group from A to B. The biggest threat here is infections setting in. Second, manage pain effectively, which can be significant with these burns, especially during dressing changes.
What kind of treatments or dressings are used for Group A?
There's a wide range of approaches used worldwide, from traditional remedies like honey to simple nonstick dressings, more advanced synthetic or biological dressings, porcine pig collagen, and even live cultured keratinocytes in some specialist centers. The source suggests the ideal dressing should be easy to apply, not painful to put on or take off, should actually reduce pain, be simple for nurses or even patients' families to manage, and be locally available and affordable.
And the dressing choice can really matter for those borderline burns.
Critically, the source emphasizes that for burns that are kind of borderline mid-dermal, not clearly superficial, but maybe not definitely deep, the right dressing choice can be the difference between the burn healing quickly with no significant scar or progressing to become deeper, requiring an operation and resulting in hypertrophic scarring. So dressing choice isn't trivial.
How are contaminated wounds handled initially? If there's dirt in it.
If a wound is heavily contaminated, say from dirt or debris in the accident, formal cleaning, sometimes in the operating room under general anesthetic, is the best approach to get it properly clean. For wounds that become contaminated later, or chronic wounds, silver sulfadiazine cream is mentioned as being very effective for 2-3 days to control bacteria before switching to a dressing that actively promotes healing.
What are some common dressing options mentioned for Group A burns?
Well, the simplest method is exposure, just leaving the burn open to the air. This is usually only practical for small burns on the face, but it's painful and requires intensive nursing to keep clean and prevent drying and cracking. A variation is using a permeable adhesive wound dressing like Mefix or Fixamol. This allows the wound surface to dry out, but prevents it sticking to sheets or clothes.
What about more traditional dressings?
Vaseline impregnated gauze, sometimes with an antiseptic like chlorhexidine added, is a traditional option. Fenestrated silicone sheets, like Mapatel, provide a non-stick contact layer. Acticoat dressings contain silver nanocrystals and provide broad-spectrum antimicrobial cover. A key advantage is they can often be left in place for up to 7 days, reducing dressing change frequency.
And what about those interactive dressings that are supposed to help healing?
Hydrocolloid dressings like Duoderm are mentioned. They're typically changed every 3 to 5 days and can be useful, particularly in burns of mixed depth, because the enzymes that accumulate under the occlusive dressing can help debride or clean up deeper patches. They provide a moist environment that helps the top layer of skin epithelium regrow. There's good evidence supporting their use in burns.
In biosynthetic or natural ones, like BioBrain?
Biosynthetic dressings like BioBrain and natural ones like amniotic membranes obtained from placentas are designed to provide a good healing environment and often don't need to be changed frequently, if at all. They are described as potentially ideal for one-stop management of suitable superficial burns because they are easy to apply and comfortable for the patient. However, they won't stick properly to deep dermal burns where the burn tissue, the eschar, needs to separate first, so they aren't as useful in mixed depth burns unless the deeper areas are surgically removed first. The source includes figures showing how BioBrain is applied and how it gradually lifts off as the underlying skin heals underneath it over about 3 weeks.
So for Group A, it's really about protecting the wound, preventing infection, managing pain, choosing an appropriate dressing to facilitate natural healing, and crucially, preventing it from getting deeper and becoming a Group B problem. Expert speaker.
Exactly.
Exactly.
Now, for Group B burns, the deep dermal and full thickness ones that won't heal well spontaneously, initial management still involves cleaning the wound and assessing size and depth, similar to Group A, but surgical intervention is usually necessary here.
Yes. For circumferential full thickness and deeper partial thickness burns, escharotomy might be required as an emergency procedure to relieve constriction, as we discussed. And virtually all but the very smallest full thickness burns will require surgical excision removing the burned tissue.
What about deep dermal burns? We're not quite sure initially.
For smaller, deep dermal burns where the depth is uncertain, or if the depth is variable across the burn, they may need 48 hours or so to declare themselves to clearly show how deep they really are. During this time, they need to be managed with appropriate dressings, often antimicrobial ones, while awaiting that clarification. Let's talk about escharotomy again in more detail. That emergency procedure for circumferential burns. When is it done?
This is an emergency surgical procedure indicated specifically for circumferential, meaning completely encircling full thickness burns affecting the limbs or the torso. The reason it's an emergency is because that stiff, inelastic burn eschar acts like a tourniquet as the underlying tissues swell. On the chest, it restricts breathing. On the limbs, it cuts off blood circulation, leading to tissue ischemia and potential limb loss.
So the surgery is simply cutting through the burned skin to release the pressure. How is it done?
Precisely. You make surgical incisions, usually with a scalpel or diathermy, through the full thickness of the eschar, the full length of the circumferential burn. For a chest burn, this typically means making 2 longitudinal cuts down the front in the mid-axillary lines, and sometimes 2 transverse cuts across the upper chest and lower costal margin, like crossing out a box. If the patient is intubated, you should see an immediate improvement in their breathing effort or lower pressures needed on the ventilator after this is done successfully.
And on the limbs, where are the cuts made?
On the limbs, the incision is usually made down the side, in the mid-axial line, medial or lateral. You have to take extreme care to avoid damaging major nerves that run close to the surface in certain areas. The source gives specific examples. Stay anterior to the medial epicondyle at the elbow to avoid the ulnar nerve in the upper limb. Stay posterior to the medial malleolus at the ankle to avoid the long saphenous vein and tibial nerve. Stay anterior to the head of the fibula below the knee to avoid the common peroneal nerve in the lower limb. On the fingers or toes, the incision is usually made down the midline on the side.
Important anatomical landmarks to avoid.
Absolutely critical. If the pressure has already built up significantly within the muscle compartments beneath the fascia, the connective tissue sheath around muscle groups, then fasciotomies, incisions into the fascia itself might also be needed. This is usually best done in the controlled environment of the operating room.
Any general rules for performing escharotomy?
Yes, the incisions should extend slightly beyond the edges of the visibly deep burn to ensure full release. Any significant bleeding points encountered should be stopped using diathermy. Cautery. Afterwards, a hemostatic dressing, one that helps stop bleeding, is applied, and the limb should be elevated to help reduce swelling. The source notes that escharotomy, while necessary, can cause significant blood loss, so the patient needs to be monitored closely.
The figures in the source really help visualize where those cuts are made. Moving on to the definitive surgical treatment of the Group B wound itself, removing the burned tissue, or excision. There seems to be some debate about the timing of this, early versus staged.
Yes, there's variation in opinion and practice worldwide on the optimal timing for excising the burn Escher. One major approach is early total burn excision. This means removing the entire burn wound, or as much as is safe and feasible, in a single large operation performed as soon as logistically possible after the patient is stabilized in the emergency room, their airway is secured, and necessary monitoring and IV access are established. The decision then is whether to take them straight from the ED to the operating room or transfer them to the ICU first for a period of further stabilization.
What's the argument for doing it so early, potentially within the first day or two?
The main argument for early excision is to take advantage of specific windows of opportunity before the body's overwhelming systemic inflammatory response to the burn really reaches its peak and causes major secondary problems.
What kind of windows are we talking about?
Well, there's what the source calls an anesthetic window. While intubation bypasses the upper airway swelling, we know that lower airway smoke inhalation injury can cause progressive chemical pneumonitis and potentially ARDS, acute respiratory distress syndrome, which often becomes most problematic after about 48 hours. Performing major, lengthy surgery before the lungs potentially decompensate significantly might be safer from an anesthetic perspective.
Okay, so operate before the lungs get too sick. What else?
Then there's the hemodynamic window. The progressive inflammatory response causes widespread vasodilation, blood vessels relaxing and widening, and can lead to coagulopathy, clotting problems. Operating earlier, before these changes are fully established, means techniques to reduce bleeding during surgery, like injecting adrenaline solutions, might be more effective. This can result in less blood loss during the procedure and a reduced need for blood transfusions, which themselves can carry risks and further suppress the immune system.
And removing the burned tissue also helps with fluid balance.
Yes, removing the Escher, which is a major source driving some of that massive fluid leakage we talked about, can result in less overall tissue edema and lower ongoing fluid resuscitation requirements after the surgery. Finally, there's the bacterial window. A full-thickness burn is essentially dead. Necrotic tissue, an ideal breeding ground for bacteria. Excising this necrotic tissue early helps dramatically reduce the bacterial load in the wound, significantly lowering the risk of invasive wound infection and sepsis.
So the arguments for early excision are remove the source of infection, operate before the lungs potentially worsen, maybe have less bleeding and lower fluid needs.
That's the summary of the potential benefits. The source does note, however, that performing large early total burn excisions requires significant and readily available resources, operating theater time, experienced staff, surgeons, anesthetists, nurses, blood bank support, and ICU capacity.
Which logically leads to the staged approach if those resources for a huge early operation aren't available or if the patient is too unstable.
Exactly. When the resources for a single large early operation aren't available, or perhaps if the patient is deemed too physiologically unstable for a massive initial procedure, a staged approach is often used. This involves serial debridement, removing the burn wound in stages over several planned operating sessions, typically spread out within the first week or so after injury.
What do proponents of this staged approach argue are its advantages?
They argue that doing shorter but potentially more frequent trips to the operating room can potentially reduce the physiological stress of each individual operation and perhaps lessen the overall need for blood transfusions compared to one very long, massive excision.
How is the wound managed between these stages of surgery in this staged approach? You still got dead tissue sitting there.
That's the key challenge. The success of staged excision relies heavily on managing the remaining burn Escher effectively between operations. You need to prevent bacterial colonization and keep the wound bed as healthy as possible in preparation for the next surgery. This is typically achieved using topical silver-based creams and dressings, which have excellent broad-spectrum antibacterial properties, including activity against common and often problematic burn wound pathogens like Pseudomonas aeruginosa and MRSA, methicillin-resistant Staphylococcus aureus.
What are some of the common silver agents used for this purpose?
Silver sulfadiazine cream, often called SSD, usually 1% concentration, is very widely used for broad-spectrum prophylaxis against bacterial growth on the wound surface. Mafenate acetate cream is popular in some places, particularly the USA, although the source notes it can be painful when applied and is associated with a potential side effect of metabolic acidosis. It's usually used as a 5% topical solution.
Any others mentioned?
The source also mentions a combination product, silver sulfadiazine combined with cerium nitrate. This combination is noted for inducing a particularly tough, sterile eschar, and has been shown in some studies to potentially reduce some of the cell-mediated immunosuppression associated with burns, especially in elderly patients. The cerium component is thought to have some immune-boosting effects. Acticoat, that dressing with nanocrystalline silver we mentioned earlier, is also listed here as an effective, broad-spectrum antimicrobial barrier dressing suitable for managing wounds between staged excisions.
So staged excision involves multiple surgeries over time, using these topical agents to keep the wound clean and controlled between procedures.
Yes, managing the eschar effectively is crucial in that strategy. Regardless of whether an early total excision or a staged approach is taken, the source emphasizes that control is the keystone of successful burn surgery.
Control of what specifically during the operation?
Control of the patient's physiological state during the procedure, and particularly meticulous control of bleeding. This requires robust intravenous access. Wide-bore cannulas are essential and adequate, often invasive, blood pressure monitoring. For larger excision procedures, an arterial line for continuous beat-to-beat blood pressure measurement and central venous access for fluid drug administration and monitoring are usually necessary.
The anesthetist plays a huge role here, monitoring everything.
A critical one. The anesthetist must continuously monitor and actively manage the patient's acid-base balance, their clotting status, using point-of-care testing if available, and their hemoglobin levels, coordinating blood product transfusion as needed. It's also absolutely vital to prevent the patient's core temperature from dropping below 36 degrees C during these often long surgeries, as hypothermia significantly worsens clotting problems and increases bleeding.
How is blood loss controlled actively during the excision itself?
Several techniques are employed routinely. A dilute solution of adrenaline, epinephrine, is often injected subcutaneously into the tissues just before excision to constrict local blood vessels. The source mentions concentrations like 1.1 million or 1.500,000. Tourniquets can be used to control bleeding during surgery on limbs. And tumescence fluid, usually a large volume of saline solution containing dilute adrenaline, is often injected into both the burn eschar that's being removed and the areas where skin grafts will be harvested from donor sites to help reduce capillary bleeding.
Let's talk about the actual technique of removing the burn tissue. The source mentions tangential and full-thickness excision. How are they different?
Tangential excision is the technique typically used for deep dermal burns, Group B burns where some viable dermis remains. The surgeon uses a specialized sharp instrument, like a dermatome or a Watson knife, to shave off thin layers of the burned tissue tangentially, parallel to the skin surface, until they reach healthy, viable dermis. This endpoint is usually indicated by the appearance of diffuse punctate bleeding, tiny pinpricks of blood appearing uniformly across the excised surface, and the absence of small, visible, clotted blood vessels within the remaining dermis. Applying topical adrenaline solution, for example 1.500,000 to the surface, also helps reduce bleeding. Once excised, the wound is ready for coverage, usually with a skin graft or substitute.
And for full-thickness burns, where the whole dermis is gone.
Full-thickness burns mean the entire dermis is destroyed, so there's no viable dermal layer to tangentially excise down to. These require full-thickness excision of the burned skin, removing it usually down to the level of healthy subcutaneous fat, or sometimes even deeper down to the fascia covering the underlying muscle, if the burn extends that deep.
And coverage should happen immediately if possible.
Yes. Wherever possible, the excised area, whether from tangential or full-thickness excision, should be covered immediately during the same operation with a skin graft or a suitable skin substitute to achieve wound closure. The source shows figures illustrating marking a full-thickness burn on a leg, excising it down to healthy underlying tissue, fat or fascia is visible, and then the appearance of a skin graft applied to that area at the first dressing change.
So once the burn tissue is removed, the wound needs cover. The source goes into quite a bit of detail on split skin autografts, which sound like the workhorse.
They are. The goal of applying a skin graft after excision is to achieve primary intention healing, meaning the wound closes directly by the graft, taking and integrating, rather than filling in slowly from the edges and base. A split skin autograft, or split thickness skin graft, STSG, is a thin layer of the patient's own healthy skin harvested from an unburned area, the donor site. It consists of the epidermis, the very top layer, and a variable proportion of the superficial dermis beneath it. The source specifies a typical harvest thickness between 0.30 and 0.38 millimeters, so less than half a millimeter thick.
And harvesting this graft creates a new wound, the donor site, that also has to heal.
Exactly. The donor site is essentially a superficial, partial thickness wound that needs to heal itself by reepithelialization from the remaining dermal elements. Because split skin grafts are thin and contain much less of the supporting dermal collagen structure than full thickness skin, they are prone to contraction after they are applied and during the healing process.
Does the thickness matter for contraction?
Yes, generally the thinner the split skin graft harvested, the greater the degree of subsequent contraction. This contraction can lead to functional disability if it occurs over joints, and can also cause uncomfortable sensations like dysesthesia, altered or painful sensation in the grafted area.
And the donor site is notoriously painful, right? And you only have so much donor skin.
It is one of the most painful aspects for patients, yes. And you're right, donor skin is a finite resource. Techniques are used to try and get as much coverage as possible from a limited donor site area, especially in large burns. One very common technique is meshing the graft.
How does meshing work exactly?
After harvesting the sheet of split skin graft, it's passed through a specialized device that looks a bit like a pasta maker. It has rollers mounted with blades that cut small, parallel, offset slits in the graft. These slits allow the graft to be expanded and stretched like opening up a net or mesh, creating a pattern with diamond-shaped openings between the strands of intact skin.
What are the main advantages of meshing the graft?
The primary advantage is that it allows a smaller piece of harvested donor skin to cover a significantly larger area of excised burn wound, which is crucial in big burns where donor sites are scarce. A secondary advantage is that the openings in the mesh allow blood or fluid seroma that might collect under the graft to escape, reducing the risk of the graft lifting off and failing to take.
And the mesh ratio, what does that refer to?
The mesh ratio, example 1.1.5, 1.2, 1.3, 1.4, refers to how much the graft is expanded. A 1.3 mesh means the graft is stretched to cover 3 times its original harvested area. Higher ratios mean the cuts are pulled wider, creating larger diamond-shaped openings between the skin strands.
How do those openings, the diamonds in the mesh, actually heal?
The areas between the mesh strands don't contain the necessary skin structures, like epidermis or deep dermal elements, to re-epithelialize quickly from the edges in a large wound bed. A small amount of granulation tissue, that pink, bumpy healing tissue, forms in these openings from the underlying wound bed. However, this healing process within the mesh diamonds leaves a characteristic permanent mesh pattern scar. Generally, the wider the mesh ratio used, i.e. the larger the diamond defects, the worse the final cosmetic appearance of the scar.
So meshing helps cover more area, but results in a less aesthetically pleasing scar? And the donor site itself, how does it heal? Does it return to normal?
The top layer, the epidermis, can regenerate from epithelial cells remaining in the hair follicles and sweat glands left behind in the deeper part of the dermis at the donor site. However, the portion of the dermis that was harvested with the graft can only repair by forming a scar layer under the new epidermis. So the donor site area is permanently thinner dermally than it was before harvesting. It's not an infinite resource.
Can you harvest from the same site again?
Yes, once it's healed, but with multiple harvests from the same area over time, which is often necessary in very large burns, serial harvesting, the donor site can become progressively thinner and more scarred. Eventually, it can become so deep that it won't heal well on its own, and may even require a skin graft itself to close.
That's a real challenge of those very extensive burns where donor site availability is the limiting factor.
A major challenge. When dealing with very large burns, say 50% TBSA, surgeons often have little choice but to use higher mesh ratios like 1.3, 1.4, or even higher, up to 1.9 in extreme cases, and sometimes harvest thinner grafts initially. Thinner grafts tend to heal the donor site faster, allowing it to potentially be reharvested sooner if needed for subsequent serial grafting procedures.
Are split skin grafts ever used as solid sheets without being meshed?
Yes, definitely. They're preferably left as intact sheets, unmeshed, when grafting certain critical areas where minimizing contraction and maximizing functional or cosmetic outcome is paramount. This includes grafting over major joints, onto the hands and fingers, the anterior front aspect of the neck, the face, and the dorsum back of the hands. Also, potentially over developing breasts in children to allow for future growth. However, the source is very clear and pragmatic on this point. Even with the best techniques, split skin grafts can never result in truly normal skin. They are a repair, a patch, not a regeneration of perfect skin.
That's an important reality check. After this complex surgery of excision and grafting, what does the postoperative management and rehabilitation involve? It doesn't end with the surgery.
Far from it. Careful monitoring continues to be key fluid balance, and hemoglobin levels need close attention, particularly because of potential ongoing oozing from grafted areas and donor sites on top of any blood loss during surgery. Outer dressings require regular attention and changing due to expected fluid and blood leakage, especially in the first few days.
And rehab starts immediately, even while grafts are healing.
Yes, physiotherapy and occupational therapy are vital components of post-operative care, starting very early, often from day one post-op. Using splints is important for maintaining range of movement in joints and preventing contractures, the tightening and shortening of the healing tissues that limits movement. Elevation of grafted limbs is also important to reduce swelling and help graft adherence.
How are joints typically splinted after grafting?
It's a balance. Hands are often splinted in a position of function, wrists slightly extended, MPs flexed, IPs extended, some abducted. Although the skin graft itself needs to be applied with the hand and joint stretched maximally during surgery to counteract contraction during healing. Knees are best splinted in extension, kept straight, and axillae armpits are splinted in abduction, with the arm raised away from the body to prevent webbing contractures.
And movement begins when? How soon can they start moving the grafted areas?
Supervised movement by physiotherapists should begin relatively soon after grafting, typically after about 5 days, once the graft is thought to be adherent. This is often done initially with direct visualization of the affected joints to make sure the grafts aren't being sheared or disturbed. Once the wounds are fully healed, the focus shifts increasingly toward long-term scar management and helping the patient regain independence in their previous activities of daily living.
So, summarizing the excision surgery part, deep dermal burns usually need tangential shaving down to bleeding dermis, followed by grafting or perhaps dermal substitutes. All but the very smallest full-thickness burns need surgical excision down to healthy tissue. The anesthetist must be prepared for significant blood loss and manage the patient carefully. Techniques like tumescence fluid and topical adrenaline help reduce bleeding. All the burnt tissue needs to be excised. And stable wound cover, whether permanent, like an autograft, or temporary, should be applied immediately whenever possible.
That covers the core surgical approach to the burn wound itself. Now let's talk specifically about the challenges and solutions for skin grafts and substitutes used in those very extensive burns, where the limited amount of the patient's own healthy donor skin is the biggest challenge.
Right, this is where you have more burn than healthy skin to cover it. Those 50% TBSA burns.
Exactly. For burns covering more than, say, 50% of the total body surface area, achieving complete wound closure quickly using only the patient's own skin was historically a major, often insurmountable problem simply because the area to cover was much larger than the available donor skin area for split skin autografting. While the split skin autograft remains the mainstay for permanent repair for these massive burns, surgeons rely on several maneuvers combined to try and cover as much wound as possible over time.
What maneuvers are used to stretch that limited donor skin further?
Techniques include planning for serial grafting episodes, taking the patient back to the operating room multiple times over weeks or sometimes months to harvest more skin as donor sites heal enough to be reharvested. Harvesting very thin autografts, maybe 6 to 8 thousandths of an inch, allows the donor sites to re-epithelialize faster, enabling earlier reharvesting from the same site when multiple harvests are needed. As we discussed, widely meshing the grafts using very high expansion ratios like 1.3, 1.4, or even up to 1.6 or 1.9 in extreme situations stretches the skin to cover a much larger area, although this results in those prominent mesh scars with slow healing in the gaps. And the Meek-Wall micrografting technique is another specialized method.
What is the Meek-Wall technique again? How does that help?
This is a technique that takes small pieces of harvested split skin graft, typically about 3 millimeter by 3 millimeter squares initially. These are placed onto a specialized holder backed by corkboard and then run through a machine with perpendicular blades that cut them into even tinier fragments. The holding platform is then pulled apart, like stretching a mesh, achieving different expansion ratios, and separating these tiny skin islands. The big advantage is that it allows even very small or irregularly shaped pieces of harvested graft to be effectively meshed and expanded, minimizing wastage and maximizing coverage from very limited donor sites. However, it's described by the source as a fiddly and laborious technique to perform.
It sounds incredibly intricate, but potentially life-saving in those massive burns. What about using skin substitutes? like skin from deceased donors, cadaver skin.
Cadaver skin, also called allograft, gained popularity, particularly in the late 20th century, as a way to temporarily cover large, excised burn wounds that couldn't be immediately closed with the patient's own skin autograft. It was used as a biological dressing, buying time while waiting for the patient's limited donor sites to heal enough to be reharvested. Refinements in consent processes, harvesting techniques, and storage methods, skin banking, made it more available.
But it's only a temporary solution, right? It gets rejected.
Yes, and it has significant limitations. Skin banks often struggle with supply and demand, so it might not always be available. More fundamentally, it provides only passive temporization. It just covers the wound, protecting it from infection and reducing fluid and heat loss, but it doesn't actively improve the quality of the wound bed or promote organized new tissue growth underneath. It just allows somewhat undirected granulation tissue to form beneath it. And crucially, because it's tissue from another person, it will be rejected by the patient's immune system, usually within a couple of weeks, unless the patient is profoundly immune suppressed, which burn patients often are, but rejection still occurs. So it has to be removed and replaced.
So it just buys time, doesn't really improve the quality of the healing bed or integrate permanently. It's a temporary biological bandage.
Exactly. This limitation led to the development of a different strategy, the dermal matrix or dermal substitute strategy, pioneered by researchers like Jack Burke and Ioannisianis at MIT and the Shriners Burns Hospital in Boston.
What was their different approach? What's a dermal matrix?
The core idea was to create a scaffold material initially made from collagen derived from animal sources, cross-linked with other molecules that could be placed on the excised wound bed. This scaffold would then allow the patient's own cells, their autologous tissue, specifically fibroblast cells and blood vessels, to grow into it over several weeks, effectively building a new layer of dermis, a neodermis. This is considered active temporization because it's not just passively covering the wound, but actively guiding the formation of new organized dermal tissue.
And did this improve outcomes compared to just grafting onto the raw wound?
It did, particularly for the quality of the final result. Applying thin, meshed split skin grafts over this newly formed, more organized neodermis after removing the temporary outer layer of the scaffold resulted in better outcomes compared to grafting directly onto a raw, excised wound bed, especially in terms of reduced scar contraction, improved pliability, and better cosmetic appearance. A completely synthetic, biodegradable polymer version of this concept was later developed. An example mentioned is the biodegradable temporizing matrix, or BTM.
The source includes figures comparing immediate grafting to using BTM first before grafting. What do they show?
Yes, figure 46.9 shows a patient where BTM was applied to the arm wounds after excision, while the chest wound received an immediate skin graft. Figure 46.10 then shows the subsequent mesh graft applied to the arm after the BTM had integrated and its temporary outer layer was removed. It compares the scar outcome at 200 days between the immediate chest graft and the BTM plus skin graft on the arm using the same mesh ratio for the grafts.
And what do the figures suggest about the outcome with BTM?
Visually, they suggest that using the BTM first to effectively build that dermal layer before applying the final skin graft resulted in a better quality scar, seemingly less mesh pattern visibility, perhaps more pliable compared to applying the same mesh ratio skin graft directly onto the excised wound on the chest.
That seems like a significant step forward, aiming not just to close the wound, but to actively improve the underlying tissue quality and potentially the long-term scar outcome, trying to rebuild a better foundation first.
It's certainly a move in that direction, trying to regenerate something closer to normal skin structure rather than just patching the defect. It adds complexity and time, but potentially improves the quality of the reconstruction.
Beyond the complex surgical techniques for the wound itself, the source covers several other crucial aspects of treating the burned patient throughout their journey. Analgesia pain control is one that touches every stage, isn't it?
Absolutely vital. Managing pain, both the constant background pain and the sharp procedural pain, is fundamental to humane and effective burn care from the very outset. For small, especially superficial burns, simple oral pain medication like paracetamol, acetaminophen, and NSAIDs like ibuprofen, along with the soothing effect of topical cooling, is usually sufficient.
But for larger burns, that's nowhere near enough, presumably.
No. Large burns are incredibly painful and require potent pain relief. Intravenous opiates, like morphine or fentanyl, are usually needed for initial management and background pain control. The source specifically advises against using intramuscular injections for pain relief in burn patients, as absorption from muscle tissue can be very unreliable due to the circulatory changes.
And for ongoing pain, and especially for procedures like dressing changes.
Patients with large burns typically need continuous background pain management, often starting with intravenous infusions and then transitioning carefully to long-acting oral medications as they stabilize and recover. They will also need powerful, short-acting pain relief given specifically before predictably painful procedures like dressing changes or physiotherapy sessions. Managing this procedural pain effectively requires skill and planning, sometimes involving anesthetists using techniques like general anesthesia, conscious sedation with drugs like midazolam or ketamine, or less intensive methods supervised by nurses like patient-controlled analgesia, PCA with morphine, or inhaled nitrous oxide gas and air.
So it needs a multimodal approach.
Definitely. The source notes that getting specialist colleagues from the acute pain team involved early on is very beneficial in developing an effective, individualized pain management plan.
So comprehensive pain management is integrated throughout their hospital stay and rehabilitation. What about energy balance and nutrition? You mentioned gut issues earlier, and the body must be using huge amounts of energy to heal.
Yes, exactly. Major burns create a profound state of hypermetabolism. The body's metabolic rate skyrockets, burning energy at an incredibly high rate as it tries to cope with the massive injury, fight infection, and heal the wounds. Any adult with a burn over 15% TBSA or a child over 10% TBSA has significantly increased nutritional requirements.
How is that managed? How do you get enough calories and protein into them?
For patients with burns of 20% TBSA or greater, the recommendation is that nutritional support should be started very early, ideally within 6 hours of the injury. This is usually done using a feeding tube passed through the nose into the stomach, nasogastric or NG tube, or preferably into the small intestine just beyond the stomach, nasojejunal or NJ tube.
Why start feeding so early?
Early enteral feeding directly into the gut, is important for several reasons, including helping to maintain the integrity and function of the gut lining and potentially reducing that bacterial translocation we talked about earlier. Using a nasojejunal tube has the practical advantage that the patient doesn't necessarily need to be fasted for trips to the operating theater, as the feed is delivered beyond the stomach.
Who oversees this complex nutritional support?
A specialist dietitian is a key member of the multidisciplinary burn team. They calculate the patient's specific energy and protein requirements using various formulas, like the Carreri formula or others based on indirect calorimetry if available, and manage their nutritional balance throughout their stay. Burn injuries put the body in a severely catabolic state, meaning it's breaking down its own tissues, like muscle, for energy. Successfully managing this involves several strategies.
How do you counteract that catabolic breakdown?
The single most significant factor in reversing the catabolic drive is achieving rapid surgical excision of the burn wound and obtaining stable wound coverage. The hypermetabolic catabolic state continues as long as there's a large, open, unhealed wound driving the inflammatory response.
So closing the wound helps shut down that metabolic fire.
It's the biggest factor. Other strategies include minimizing the energy the body has to utilize for other things, for example, by keeping the patient consistently warm with good environmental temperature control, reducing the energy spent trying to maintain body temp, and of course providing enough, often significantly excess energy and protein through carefully calculated enteral or sometimes supplementary parenteral intravenous feeding. Progress is monitored by tracking the patient's weight and often by measuring their nitrogen balance, comparing nitrogen intake from protein with nitrogen losses in urine, etc., to ensure they are getting enough protein for healing.
So covering the wound is crucial not just for local healing, but for stopping the body from essentially consuming itself. Let's talk about monitoring and controlling infection. You mentioned major burns make patients immunocompromised. That must be a constant battle.
It is a huge challenge. Patients with major burns become steadily more immunocompromised due to the complex interplay of the inflammatory response, stress hormones, nutritional depletion, and the injury itself. At the same time, the burn wound provides a massive open portal for pathogenic and opportunistic bacteria and fungi to enter the body. Local defenses in areas like the lungs, if there's inhalation injury, and the gut are also compromised by edema and damage. And necessary medical devices like intravenous lines, central lines, breathing tubes, and urinary catheters also represent potential entry points for pathogens.
So a vulnerable patient with lots of ways for bugs to get in. How does infection control start?
It begins with the absolute basics. Strict adherence by all staff to fundamental infection control policies like meticulous hand washing, use of personal protective equipment, gloves, gowns, and environmental cleaning to prevent cross-contamination between patients. Bacteriological surveillance is also crucial, regularly taking swabs or cultures from the wound surface, from sputum if there's inhalation injury, and from the tips of catheters and lines when they are removed, helps build a picture of the microbes that are colonizing the patient over time.
And if there are signs of actual infection developing.
If there are clinical signs suggestive of infection, which aren't always as simple as a high temperature in these patients, further specific cultures, like blood cultures, are taken, and antibiotic treatment is usually started promptly. Often, the initial choice of antibiotics is empirical, a best guess based on the most likely pathogens causing the suspected type of infection, guided by the unit's common bugs and the patient's earlier surveillance results. Close collaboration and communication with a clinical microbiologist is absolutely essential to guide antibiotic choices, adjust therapy based on culture results and sensitivities, and manage potentially resistant organisms effectively.
You mentioned temperature isn't always a clear sign of infection in large burns. Why is that?
No, it can be misleading. In patients with large burns who are in that hypermetabolic catabolic state, the hypothalamus, the body's thermostat in the brain, often resets their baseline core body temperature slightly higher than normal, perhaps consistently above 37 degrees C or even 37.5 degrees C. So, a truly significant fever indicating infection is typically considered a temperature above 38.5 degrees in these patients. Other signs are often more helpful to the clinician in spotting infection early.
What are those other signs that might indicate infection?
They include things like a significant and unexplained rise or fall in the white blood cell count, an increase in the platelet count. Thrombocytosis is common with inflammation infection, worsening signs that the body is breaking down tissue, increasing catabolism, and perhaps most importantly, a general decline in the patient's overall clinical condition. They just look and feel sicker, might become more confused, or their organ function might start to deteriorate. It's often a combination of factors rather than one single sign.
So it's a complex picture requiring constant vigilance, good basic hygiene, surveillance, and teamwork with microbiology. Moving away from the direct medical and surgical treatments, nursing care is clearly fundamental throughout this process.
Absolutely. Patients with major burns require incredibly intensive, specialized, and skilled nursing care around the clock. Burn nurses are often the primary caregivers who are implementing many of the decisions and interventions that directly affect wound healing, pain management, mobility, nutrition, and the patient's overall comfort and psychological well-being. Daily tasks like managing complex dressings on bandaged hands, assisting with painful but necessary exercises for stiff joints, and facilitating personal hygiene, including carefully managed baths or showers, which are vital for wound care and physiotherapy access, but can be agonizingly painful, require immense technical skill, patience, and empathy.
And the psychological impact of how those daily, often painful tasks are managed must be significant.
Hugely so. The success or failure of these essential tasks, and crucially, the way they are managed by the nursing staff with compassion and encouragement, has a powerful psychological impact on both the patient, who may feel helpless or overwhelmed, and their family. The trust built during these difficult moments is absolutely vital for the patient's cooperation and recovery.
That leads us naturally to the specific roles of physiotherapy and occupational therapy.
Yes, these are critical from day one. All burns cause swelling, edema, and this is particularly problematic in areas with complex anatomy and function like the hands and over joints. Strategies like meticulous elevation, keeping the burned limb raised above the heart level, appropriate splinting of joints in functional positions to prevent contractures, and early regular exercise are crucial for reducing swelling, maintaining movement, and improving the final functional outcome.
When does physiotherapy start?
Yeah.
Right away.
Physiotherapy needs to start on day one, even if it's just passive range of motion exercises and ensuring correct positioning and elevation. That message needs to be reinforced daily, involving the patient actively as soon as possible and educating the family. As the wounds heal and grafts mature, the focus shifts increasingly towards active exercises, strengthening, scar management techniques like massage and stretching, and helping the patient regain the skills needed for their previous activities of daily living, which is where occupational therapists play a huge role.
And finally, alongside all this intensive physical care, psychological support is essential.
Absolutely essential. A major burn injury is an overwhelming, deeply traumatic event, far outside the normal range of human experience for most people. It severely challenges a person's ability to cope, fundamentally shatters their sense of safety and bodily integrity, and commonly leads to significant post-traumatic stress reactions.
What kind of reactions are typical? Are they signs of a disorder?
The source notes that these reactions are often normal responses to an abnormal, horrific event, and usually are self-limiting, receding as the patient heals and recovers. Common features include intrusive reactions like flashbacks, nightmares, or distressing thoughts about the event replaying in their minds. Arousal reactions, feeling constantly on edge, jumpy, easily startled, having difficulty sleeping or concentrating, and avoidance reactions trying to avoid people, places, or activities that remind them of the trauma, sometimes leading to emotional numbness.
So early support is key.
Yes. The source highlights that early involvement from clinical psychology professionals who understand trauma and burn recovery, and actively helping the patient develop positive coping strategies to manage these reactions, are of vital importance throughout their admission and long-term rehabilitation. Addressing the psychological impact is just as important as healing the skin.
It's crystal clear that burn care is a massive undertaking involving intensive physical, physiological, and psychological support delivered by a highly coordinated multidisciplinary team over a long period.
It truly embodies multidisciplinary care at its most intense and demanding.
Let's move into the longer term now. Delayed reconstruction and scar management. This is often necessary after severe burns, especially those large, full-thickness ones, isn't it?
Yes, delayed reconstruction to improve function or appearance is very common, sometimes involving multiple surgeries over many years after the initial injury. Many of the pioneering techniques still used today for managing extensive burns and their subsequent scarring were developed in response to wartime injuries, particularly by brilliant reconstructive surgeons like Sir Archibald McIndoe and his mentor, Sir Harold Delf Gillies.
Ah, yes. The source mentions the historical anecdote about McIndoe and Gillies treating severely burned RAF pilots during World War II at the Queen Victoria Hospital in East Grinstead. This led to the formation of the famous Guinea Pig Club.
That's right. It's a remarkable story. These young pilots needed multiple, often innovative and experimental operations to reconstruct faces and hands, hence the nickname guinea pigs, which they adopted themselves. McIndoe, known as the boss or the maestro, realized that their psychological recovery and social reintegration were just as important as the surgery. He fostered a unique, supportive environment.
And the club continued for decades, didn't it?
Yes, they held annual reunion meetings for decades afterwards, highlighting the lifelong impact of these injuries and the importance of that early holistic approach. It really underscores the long-term commitment required in burn reconstruction.
It is a powerful story. In terms of specific reconstruction needs in the early period after the acute injury, what area needs particular attention to prevent long-term problems?
One area needing particular urgent attention is preventing acute contractures around the eye, specifically involving the eyelids.
Why the eyelids specifically? What's the risk?
Burns around the eyelids can quickly cause the delicate eyelid skin to scar and contract, shortening them and pulling them away from the eyeball. This leads to an inability to fully close the eye over the cornea, the clear front part of the eye. This condition, called lagophthalmos, leaves the delicate cornea exposed, especially during sleep, leading to drying, ulceration, infection, a condition called exposure keratitis, which can rapidly cause severe damage and potentially permanent blindness.
So you have to intervene quickly.
Absolutely. The source stresses that eyelids must be grafted with thin skin grafts at the very first sign of difficulty closing the eye completely before the patient develops any symptoms of eye irritation or corneal damage. It's a proactive, sight-saving intervention.
That's a crucial early reconstructive priority. What other areas often need early intervention to prevent debilitating contractures?
Any area where scarring is causing a significant loss of range of movement in a joint requires early assessment and potentially intervention, release and grafting, to prevent the contracture becoming fixed and harder to treat later. This is particularly important in joints critical for function, especially the small joints of the hand and the axilla, armpit, where contractures can severely limit reach and daily activities.
How are established contractures, those that have already formed and matured, treated later on? What are the surgical options?
The approach depends very much on the type, location, and extent of the scar contracture. For hair loss on the scalp due to burns, burn alopecia, the best treatment is often tissue expansion of the adjacent healthy hair-bearing scalp skin. Tissue expansion, which involves placing a balloon-like expander under the normal skin next to the scarred area and gradually inflating it over weeks or months to stretch the skin, is also useful for replacing other isolated burn scars in areas where there is sufficient good quality adjacent skin available to stretch.
What about treating linear scar bands that restrict movement?
For a single, tight, linear scar band that's restricting movement across a joint or skin crease, a Z-plasty is a very common and effective technique. This involves making Z-shaped incisions centered along the scar band and then transposing the two resulting triangular flaps of skin and scar tissue. This cleverly breaks up the straight line of the scar, changes its direction, and effectively lengthens the tissue in the line of the original contracture, releasing the tension. The source includes helpful figures illustrating how Z-plasties are planned and performed to release a scar band.
And for wider bands of scarring.
For wider bands of scarring, a local transposition flap, which involves moving a larger paddle of adjacent healthy tissue with its underlying blood supply into the defect created by releasing the scar, might be more useful than multiple Z-plasties.
And what about for very broad or circumferential areas of scarring where you can't just rearrange the local tissue?
In these extensive situations, simply releasing the scar contracture and putting a simple split skin graft over the resulting defect often doesn't work well in the long term. The graft bed is often poor quality scar tissue, and thin grafts tend to recontract significantly. The source states that the only real effective treatment is to completely excise the scarred, contracted tissue and replace it with higher quality tissue. The best options mentioned for this are either a full thickness skin graft, harvested from areas like the groin or clavicular region, providing more dermis and less contraction, using a dermal substitute first, followed by a split skin graft over it, as we discussed for acute burns, or transferring vascularized tissue, meaning tissue brought in from another part of the body with its own intact blood supply, typically done using a free flap procedure involving microsurgery.
So a whole ladder of surgical techniques, from local flaps like Z-plasties for simple bands, up to bringing in completely new tissue via free flaps for the most complex and extensive contractures. What about managing hypertrophic scars, those common, thick, raised, red scars that form after deeper burns heal?
Yes, hypertrophic scarring is very common after deep partial thickness burns, even those that are grafted. The source indicates that many hypertrophic scars respond well, or at least improve, with the application of pressure garments. These are custom-made elastic garments that apply continuous firm pressure, around 25 mmHg, to the scarred area. They need to be worn consistently, often 23 hours a day for a long time, typically 6 to 18 months or even longer, while the scar matures. This requires significant commitment and perseverance from the patient and family.
That's a very long treatment course. Are there any alternatives or additions to pressure therapy?
Yes. For areas where pressure garments are difficult to apply effectively, like the face, or for smaller, more localized areas of hypertrophy, silicone gel sheeting or patches can be used. These seem to help speed up the maturation and softening of the scar, possibly through hydration and occlusion. Intralesional injection of steroid medication, like triamcinolone, directly into the hypertrophic scar tissue can also help flatten and soften it, particularly for smaller or resistant scars, although it carries risks like skin thinning or pigment changes.
And are there other common issues associated with burn scars besides the thickness and contracture?
Yes. Itching, or pruritus, is an extremely common and often very distressing symptom in maturing burn scar areas. Dermatitis, inflammation, and dryness of the scarred skin is also common. The source emphasizes that pharmacological treatment for the itch, using antihistamines, gabapentinoids, or other agents, is often an essential adjunct to therapy. Controlling the itch significantly improves the patient's comfort and quality of life, and makes it much easier for them to tolerate and comply with other necessary scar treatments like pressure garments and scar massage.
We focus mostly on thermal burns from heat, but the source also covers several important types of non-thermal burn injury. Let's start with electrical burns. They sound particularly complex.
They are. Electrical injuries are typically divided based on the voltage involved. Usually low voltage, meaning less than 1,000 volts, like standard household electricity, and high voltage, meaning over 1,000 volts, like from power lines or industrial equipment.
What are the typical characteristics and dangers of low voltage injuries?
Low tension injuries, usually from touching faulty domestic appliances or wiring, typically don't involve enough electrical energy to cause widespread destruction of deep tissues between the points of contact, because the body's overall electrical resistance is relatively high at these voltages. However, the points where the electricity enters and leaves the body, often the fingers or hand and perhaps the feet, suffer small but often surprisingly deep burns, sometimes involving underlying tendons or nerves right at those contact points. There's usually little damage in between.
The source mentions muscle tetany with AC current.
Yes, if the electricity is alternating current AC, which is standard in households, it can cause muscles to contract involuntarily and sustain that contraction, leading to tetany, a continuous muscle spasm. This can make it impossible for the person to let go of the electrical source, prolonging the contact time. The main acute danger with low voltage AC exposure is interference with the heart's normal electrical pacing system, which can trigger arrhythmias or cardiac arrest. However, the source notes that the electricity itself usually doesn't cause significant, irreversible damage to the heart muscle in these low voltage cases. So, if resuscitation from the cardiac arrest is successful, the recovery should generally be lasting, assuming no other complications like brain injury from lack of oxygen.
So low voltage, typically localized deep contact burns, maybe muscle tetany preventing release. The primary life threat is electrical disturbance causing cardiac arrest, but usually without widespread tissue destruction or direct heart muscle damage. What about high tension injuries? They sound much worse.
High tension electrical injuries, over 1,000 volts, are indeed much more serious and complex, often causing devastating damage. The damage comes from three potential sources: the electrical flash, the subsequent flame burn, and the passage of the high voltage current itself through the body.
How does the flash cause damage? Is that like an explosion?
It can be. When a high tension power line contacts something grounded, like a person or equipment they're touching, immense electrical energy is released very rapidly. As the current arcs or jumps through the air, it superheats the surrounding air incredibly quickly, causing an explosive expansion. This blast wave can physically propel the victim away. The contact of the superheated air with the victim's skin, even for a very short duration, causes a severe thermal burn known as a flash burn. Furthermore, the intense heat of the flash can easily ignite the victim's clothing, causing additional standard flame burns.
And the damage from the current actually passing through the body, that's the conduction injury.
Yes, and this is often the most insidious and dangerous part of high voltage injuries. With high voltage, enough current is driven through the body tissues to cause damage not just at the visible entry and exit points on the skin, but also significant destruction to deeper subcutaneous tissues, muscles, nerves, and blood vessels between those points. The current tends to follow the path of least resistance, which often includes major neurovascular bundles. This underlying damage can be far, far more extensive than the surface skin burns might suggest. These conduction injuries are extremely serious and often lead to limb loss. The source includes graphic figures showing a high voltage injury resulting in severe damage and subsequent amputation of parts of the foot.
What are the specific immediate complications of these high tension injuries and how are they managed differently?
Due to that potentially massive, often hidden underlying muscle damage in the affected limbs, patients are at extremely high risk of developing rapid onset compartment syndrome, where swelling within the confined muscle compartments cuts off blood flow. This requires urgent diagnosis and surgical fasciotomies, long incisions through the skin and the fascia covering the muscle compartments to relieve the pressure and restore blood flow, potentially saving the limb.
What else happens with that muscle damage?
The damaged muscle tissue releases large amounts of myoglobin, a muscle protein, into the bloodstream. This myoglobin can clog up the filtering tubules in the kidneys, causing a condition called myoglobinuria and leading to acute kidney injury or renal dysfunction. Aggressive fluid resuscitation to maintain a high urine output, potentially up to 2 milligram per kilogram per hour, higher than for standard burns, is crucial to help flush the myoglobin through the kidneys and prevent kidney failure. Alkalinizing the urine may also help.
And acidosis is also common.
Yes, severe metabolic acidosis is common in large electrical burns due to both tissue damage and poor perfusion, and may require aggressive fluid resuscitation and sometimes intravenous sodium bicarbonate to correct. Patients with high voltage injuries are also at risk of direct myocardial damage injury to the heart muscle itself from the high voltage current passing through the chest. This is different from the purely electrical rhythm disturbance seen with low voltage. It can cause significant ECG changes indicative of muscle injury, elevated cardiac enzymes like troponin, and in severe cases can lead to rapid onset heart failure.
So the damage can be much more widespread and severe.
Absolutely. In cases of very severe conduction injury through a limb with extensive muscle and vascular damage, primary amputation, surgical removal of the limb immediately or very early on is sometimes deemed the most effective and ultimately life-saving initial management strategy.
So, to recap the key differences, high voltage often means widespread, often hidden, deep tissue damage along the current's path. High risk of compartment syndrome needing urgent fasciotomies. Kidney risk from myoglobinuria needing high fluid rates. severe acidosis likely, risk of direct heart muscle damage and heart failure, higher likelihood of needing amputation, whereas low voltage tends to cause more localized deep contact burns with a primary risk of electrical cardiac arrest without the same degree of widespread tissue destruction.
That effectively captures the critical distinctions in the significantly greater severity of high voltage injuries. Next, on the non-thermal list, chemical burns.
With over 70,000 chemicals in regular industrial use, the potential for chemical burns seems vast, although maybe less common than thermal.
It is a vast number of potential agents, yes. The source notes that chemical injuries involve two main aspects that need consideration. First, the direct physical destruction of the skin by the corrosive action of the chemical, and second, the potential for systemic poisoning if the chemical is absorbed through the skin into the bloodstream.
What's the crucial initial management step if you encounter someone with a chemical burn?
First, ensure your own safety with appropriate protective gear. Then, quickly determine if the chemical is a solid powder or a liquid. Solid powders, the source gives examples like elemental phosphorus or sodium metal, have specific handling requirements. They should initially be brushed off or removed carefully with forceps. Critically, water irrigation should not be used initially for these specific reactive solids, as water can cause a further violent chemical reaction and worsen the burn. However, encountering these specific solid chemical burns is relatively rare for most medical practitioners.
So what's more common, acids and alkalis?
Yes, burns from liquid acids or alkalis are much more common. The source notes that alkalis, like strong drain cleaners containing sodium hydroxide or wet cement containing calcium hydroxide, generally tend to cause more destructive, deeper damage than acids. This is because alkalis cause liquefactive necrosis, essentially dissolving tissues more thoroughly, allowing deeper penetration. Alkalis are especially dangerous if they get into the eyes, potentially causing severe and rapid damage leading to blindness.
So after ensuring safety and removing any solid powders, what's the next step for liquids?
For most liquid chemicals, acids, alkalis, solvents, etc., the absolute cornerstone of initial management after removing contaminated clothing is immediate, copious, and prolonged lavage, washing with water. Lots and lots of running water for at least 20-30 minutes, sometimes longer, to dilute and physically wash away the chemical from the skin surface.
Just keep washing.
Exactly. Once the initial copious washdown is complete, the next crucial step is to try and identify the specific chemical involved and, if possible, its concentration. This information is vital because it helps guide the rest of the management, predicting the likely depth and extent of the physical damage, and importantly, assessing whether there's a significant threat from systemic absorption and poisoning that might require specific systemic treatment or monitoring.
The source gives a specific example of a chemical with a unique systemic risk, hydrofluoric acid, HF.
Yes, hydrofluoric acid is a notable and particularly dangerous exception to the general rules for acid burns. While often technically considered a weak acid, it's uniquely hazardous because the fluoride ion, F, penetrates tissues very deeply and binds avidly, or chelates, with essential divalent cations in the tissues, primarily calcium and magnesium ions. This causes severe local tissue damage and intense pain, often delayed in onset and out of proportion to the visible burn.
How is HF exposure managed?
Dilute HF burns, often to the fingers from cleaning products, are relatively common. Initial management still involves copious washing, but is followed immediately by topical application of calcium gluconate gel, which is massaged into the affected area. The idea is that the calcium in the gel will bind with the fluoride ions, neutralizing them and reducing further damage and pain. For more severe or larger hand burns, regional intravenous Spears blocks containing 10% calcium gluconate solution can be used to deliver a higher concentration of calcium directly into the affected tissues.
So you're trying to counteract that calcium binding locally. What about systemic effects?
If the burn is caused by a higher concentration of HF, the source says greater than 50%, or involves a large surface area, there's a significant risk of systemic absorption of fluoride leading to life-threatening hypocalcemia, dangerously low calcium levels in the blood, and potentially hypomagnesemia. This can cause severe cardiac arrhythmias and be fatal. Exposure to high concentration HF is considered an indication for urgent assessment and potentially acute early surgical excision of the contaminated tissue to remove the source of ongoing fluoride absorption. Interestingly, the source advises against applying a split-skin graft to these excised wounds immediately, suggesting delaying grafting to a later stage, perhaps due to concerns about the wound bed environment after HF exposure.
So hydrofluoric acid is a special case. It causes deep pain and tissue damage by binding calcium, requiring specific topical or regional calcium treatment, and carries a significant risk of life-threatening systemic poisoning at higher concentrations, potentially necessitating early surgery.
It's a chemical burn with a unique and dangerous metabolic threat that must be recognized. Moving on briefly, ionizing radiation injuries.
This could be either whole body exposure or localized exposure, right? Like from radiation therapy.
Yes, localized radiation damage, such as might occur from accidental overexposure during therapeutic radiation for cancer or from industrial radiography accidents, is usually managed conservatively in the acute phase. This is because the full extent of the tissue damage can evolve slowly over weeks or months. If the radiation damage eventually leads to a chronic, non-healing ulcer, then surgical excision of the entire damaged tissue area, which often extends deeper than it appears, and coverage with well-vascularized tissue is required. This usually means using a free flap, tissue transferred with its own artery and vein connected microsurgically, because the surrounding radiated tissues have poor blood supply and won't support a simple graft.
What about whole body radiation exposure, like from a nuclear accident?
Sure. Whole body radiation exposure is extremely serious, causing a wide range of widespread systemic effects depending on the dose, and can certainly be fatal. The source notes that acute desquamation of the skin, meaning widespread peeling and shedding of the skin shortly after exposure in a patient who has received whole body radiation, is generally considered an indicator of a lethal dose, unfortunately leading to a slow and often unpleasant death from multi-organ failure. Even at non-lethal doses, whole body radiation causes significant systemic effects, particularly affecting the rapidly dividing cells of the gut lining, leading to severe gastrointestinal problems, and the bone marrow and immune system, leading to profound immune suppression and infection risk.
How is it managed?
Other than sometimes giving potassium iodide tablets in specific types of nuclear fallout situations to block radioactive iodine uptake by the thyroid gland, the management of significant whole-body radiation exposure is primarily supportive care managing infections, providing nutritional support, blood product transfusions, etc. for the systemic effects.
So localized radiation burns causing chronic ulcers need specialized surgical excision and flap coverage, while systemic overdose requires intensive supportive treatment. And finally, the last category of non-thermal injury mentioned is cold injuries.
Yes, cold injuries are generally divided into two types. Acute cold injuries from industrial or accidental exposure to intensely cold substances, and frostbite from environmental exposure. Acute cold injuries, like exposure to liquefied petroleum gas, LPG, or liquid nitrogen, cause epidermal and dermal destruction similar in mechanism to thermal burns, just via freezing instead of heating. However, the source notes that tissue is generally more resistant to cold than heat, and the subsequent inflammatory reaction tends to be less marked. Assessing the true depth of damage from these acute cold burns can be more difficult initially compared to thermal burns, and early surgery is usually not indicated.
And frostbite, from being out in the cold too long.
Frostbite typically affects the extremities, fingers, toes, nose, ears in cold climates. The recommended initial treatment is rapid rewarming of the affected part, usually in a warm water bath, carefully controlled at around 42 degrees C. Similar to ischemia reperfusion injuries seen in other contexts, the tissue damage in frostbite occurs not just from the initial freezing, but also significantly from the subsequent microvascular damage, clotting, inflammation, that develops during and after the rewarming process. Again, the final level of actual tissue damage can be very difficult to assess accurately in the early stages. Surgery usually does not play a role in the acute management of frostbite. Instead, treatment is generally conservative, often involving medications to improve blood flow and prevent clotting, while waiting patiently, sometimes for weeks, until there is absolute clear demarcation between the viable tissue and the non-viable tissue that may require eventual amputation.
So for both acute cold contact injuries and frostbite, assessment of death is challenging early on, and the initial management is often much more conservative compared to thermal burns, generally avoiding early surgery and waiting to see the full extent of the damage as it declares itself over time.
That's the key distinction compared to deep heat burns, where early excision and grafting is often the goal. With cold, patience and supportive care are usually the initial approach.
We've covered an incredible amount of ground in this deep dive, delving into the mechanisms, the systemic effects, the assessment, the critical immediate life-saving care, the complex surgical interventions, the challenges of reconstruction, and the management of all these different types of burn injuries. The source concludes by briefly mentioning recent advances and future directions.
Yes, it acknowledges that major advances in burn care over recent decades have come from incorporating advanced technology, like new ventilators, monitoring systems, newer drugs, antibiotics, pain medications, immunomodulators, and particularly the development and refinement of skin substitutes, like the dermal matrices we discussed, into routine practice.
And where is the focus for the next steps?
The future focus and next steps highlighted in the text point towards areas like cultured autologous skin, essentially trying to grow larger sheets of skin in a laboratory using a small biopsy of the patient's own skin cells, their keratinocytes, epidermal cells, and potentially fibroblasts, dermal cells, with the ultimate goal of creating truly bioengineered permanent skin replacements that might one day overcome the limitations of donor site availability and graft quality.
But the source adds a note of caution about the use of these expensive new technologies.
It makes an important point, yes. With the development of increasingly sophisticated and often expensive technologies and materials, it's crucial to ensure their intelligent and appropriate use. They need to be rigorously evaluated to demonstrate clear clinical benefit and effective cost-benefit ratios, as burn care is already an incredibly resource-intensive field of medicine. We need to ensure these advances are used wisely.
Wow. This has been a truly comprehensive and honestly quite intense deep dive into the complex world of burn injuries, all guided by this detailed chapter from Bailey and Loves. We've journeyed from understanding the basic incidents and causes,
Through unraveling the intricate pathophysiology affecting almost every organ system,
the critical steps of assessment size and depth, and the immediate life-saving care in the ATLS framework.
the complex surgical techniques for excision and grafting, the evolving role of skin substitutes,
Long-term reconstruction and scar management, and the unique challenges presented by non-thermal injuries like electrical, chemical, radiation, and cold burns.
it absolutely highlights just how incredibly complex and demanding burn care is. It requires rapid, highly skilled assessment and a deeply coordinated, persistent effort from a large, multidisciplinary team at every single stage, from the moment of injury through potentially years of rehabilitation and psychological support.
And along the way, we've encountered some of the key figures whose names are attached to the concepts and techniques mentioned in the source pioneers, like Lund and Browder for the assessment chart, Wallace for the rule of nines, Muir and Barclay for a fluid formula, Burke and Yanis for dermal regeneration, the reconstructive giants McIndoe and Gillies of the legendary Guinea Pig Club, Meek and Wall for micrografting, Tukolsky for his sign, and those associated with the widely used intravenous fluids like Hartman and Ringer, and even Beer for his regional block technique. Their work really shapes our understanding and treatment of these devastating injuries.
Their contributions, built up over decades, form the bedrock of modern burn management strategies.
As we wrap up this deep dive, it really leaves you contemplating the ongoing challenges in this field.
Yeah.
It's clearly not just about ensuring patient survival from these often initially life-threatening injuries, but about the immense ongoing challenge of restoring their quality of life afterwards regaining optimal function, minimizing the long-term burden of pain and scarring, and supporting their psychological recovery and social reintegration after such a physically and emotionally traumatic experience.
You're looking forward, with the continued advances in technology, biomaterials, and tissue engineering that the source touches on, what possibilities does the future truly hold? Can we move beyond just repair towards true regeneration? Can we restore not just the physical structure, but the full function, the sensation, the appearance, the normality of severely burned skin? It's a field that continues to push the very boundaries of reconstructive surgery and regenerative medicine.
An incredibly challenging, complex, but vital area of medicine requiring immense skill, resources, and compassion. Thank you for joining us for this very deep dive into the world of burn injuries.